welcome to Neonatal Simulation. Today, we are really very excited to have this group. My name is Charlita Guillory, and I'm a neonatologist at Texas Children's Hospital and Baylor College of Medicine. And three of my colleagues are here, and they have really gone through a lot. First of all, I think we have a water problem in Houston. And so I'm not sure what has happened with that. And both of these doctors had to round this morning in the neonatal intensive care unit before bringing all of this to share with you. So I want you to just keep that in mind, because I'm keeping it in mind. Yay! First of all, we have Dr. Mona Khattab. And Dr. Khattab is an assistant professor of pediatrics and neonatology at Baylor College of Medicine, as well as the program director of Neonatal Simulation. She received her MD from the Alexandria Faculty of Medicine. She did her residency at State University of New York at Stony Brook and Cairo University Children's Hospital. And she did a fellowship in neonatology at Yale University School of Medicine. She's board certified in both pediatrics and neonatal medicine, and her research includes stimulation in healthcare and radiation exposure in premature neonates. So the next person I want to introduce is Dr. Nathan Sundran. Dr. Sundran is an assistant professor of pediatrics in newborn at Baylor College of Medicine, and he is co-director of the In Situ Neonatal Resuscitation Program Education at Texas Children's Hospital. His research uses methods of simulation to study better ways to improve NRP performance. He also leads a multidisciplinary team of nurses, doctors, respiratory therapists, and safety personnel made up from both neonatology and obstetrics department called the Golden Hour team. And I think we had a lecture on the Golden Hour already previously. Their goals are to improve the quality of care in the delivery room in the first critical hours of life of babies. Dr. Sundran received his MD and his PhD in physiology and pharmacology from Oregon Health and Science University. He did his medical residency at UT Southwestern. And finally, we have Dr. Ann Stark. Oh, did I do that? Sorry about that. That was a slip of the tongue. I do think of Ann Stark, though, when I see Ann, because she has her energy and commitment, so that's probably why. Can you just delete that last?
It's a privilege to be equated with her, so.
Dr. Ann Blake is a neonatology fellow at Baylor College of Medicine and Texas Children's Hospital. Dr. Blake's primary academic interests are maternal-infant bonding in the NICU, and she will be working with the collaborative on the postpartum depression screening project, so we're excited about that. Her interest, of course, is in mental health of NICU family members and neonatology advocacy. Dr. Blake is the AAP District 7 SOPT?
Section on Pediatric Trainees.
Section on Pediatric Training Advocacy Chair. So as you can see, these three are extremely committed to this program. And actually, I was talking to the collaborative members. Hopefully next year when they do this, I'm getting a commitment early, that perhaps we can work at getting some type of certificate, so that you can do your training while you're here, and it'll count. We can see how that works. So now I'm going to turn it over to the three well-qualified guests. Thank you.
Thank you so much for coming. It's been a long 2 days, and so this is an extra late in the afternoon, 3 o'clock simulation that you're only coming to because you really want to learn, you really want to try to improve your skills. And we've been talking so much about how excellent care is a matter of passion and dedication. I think staying at 3 o'clock in the afternoon just for a little extra training really demonstrates a lot of passion on all of your parts. So thank you, and we really want to try to be respectful of your time. The first hour or less. We don't want to try to use the whole 2 hours. We're going to run through 2 simulations, and then at 4 o'clock, what we'll do is stop the organized simulations where we're all watching and just allow people to come use the dolls and practice skills independently with sort of tutoring one-on-one. The idea will be that we run through 2 simulations, and if you're not part of the primary participation team, we'll all participate in the debrief after and talk about the art of the debrief. So personally, I didn't know what a debrief was until I went to fellowship. I'd been through multiple codes throughout all of residency, and I'd had the experience of being in many codes, and you walk away as often the most subordinate person on the team, not knowing if you did the right thing or if you caused more harm or if you were as helpful as you could be, and there was no discussion about it. And then I came to TCH and learned that there's this thing called the debrief, and it's really improved my ability to participate in a code and then lead a code and also feel better when I walk away from a code, to not only be able to learn from those experiences, but also to be able to not be traumatized by whatever went on in the unit that day that precipitated a code. So if nothing else, hopefully you walk away really feeling confident about the art of the debrief and recognizing that that's as necessary a skill in a code as any other part, including intubation, because also it's a service to the most subordinate people on your team and an opportunity for nurses and RTs and medical students and whoever to be a part of the team and know that they did the best they could. So with that, just because people are still finishing their drinks and snacks and it's a long day, we wanted to play a clip just to, here.
So I would like to get a sense of our audience actually first. Who here runs simulation in their units? Excellent. And who does debriefing in real environment after clinical codes? Excellent. Is there any special training you got for debriefing, or was it the NRP training? The NRP. Okay. So actually, I'm going to add to what Anne mentioned. We're going to run through the 2 scenarios. We're going to debrief it, and we're going to have debriefing of the debriefer. So somehow we will, at some point, we will get at evaluation of the debriefing and how to get to the maximum benefit from running a debrief in the clinical environment, not just in the simulation. Okay?
All right.
Trajectory's holding steady, right on the line.
Okay, we're in program 64. Oh, 5G, so we're feeling that gravity now.
Houston, we're at 400,000 feet. That's the entry interface. Story here. I got corridor light. We're coming in too shallow. I'm going manual. Houston, switching to okay, we're 3 Gs.
It's easy.
5 Gs. We're coming in too steep. I'm gonna stay in this roll, see if I can pull this out. We're at 8 Gs. 9. 10. We're at 12 Gs. 12 Gs, we're burning up. Damn it. I gave a false indicator light right at entry interface. Even Mattingly didn't get it the first time.
How you feeling, Fredo?
Charbroiled.
What happened?
Came in too steep. We're dead. No shit.
Yeah, we were in program 67 there, so. Okay, guys, we're gonna do this again, obviously, but.
Jim, could we have a word?
Sure, Steve. Well, if I had $1 for every time they killed me in this thing, I wouldn't have to work for you, Dean.
So all the
To say that it's really okay to make mistakes here, and we hope that you do. And that the point is that this is a safe space, and that the more we risk now, the better we take care of our patients later when it really is a life and death situation. And that's why these simulations, even though it's 3:00 in the afternoon on your own time, and it's like a sleepy hour, these are hugely important and some of the most important practices we do for our patients. So thank you so much. And with that, we'll get underway with the first simulation.
So while we're preparing our mannequin for the simulation, you all know, I'm sure, that actually simulation started in NASA. This is what they use for safe operations outside Earth. So it's like basically there is no space for any mistake. And that's what we're trying to bring to healthcare. So simulation is like a safe way for people not just to learn skills, not just to go through scenarios that might happen in real life. It's also what we call communication and crisis resource management skills. Anyone is familiar what that means? I'll point to you because I know you. Mm. Yeah. Excellent. So basically, you could be the most experienced person in the room. You could probably know what's going on and know exactly what needs to happen and what management for this case is, what the management for this case is. But unless you're able to communicate it and communicate it effectively with the team and have use all the four items or four principles of crisis resource management skills, the outcome might not be as good as you would expect. So it includes good communication, leadership, situational awareness, and anticipation, like utilization of resources. Okay, so we're gonna practice a scenario here, but we're not just looking basically for medical knowledge or working on management of that case. We're also gonna talk in the brief the crisis resource management skills. And I'm sorry, I'm short of breath. I have my asthma. Actually, I wasn't sure I'm gonna be able to make it.
Yeah, here.
How about we, so what we want to do now is do the scenario. I thought Mona was going to talk a lot less today because she told me she had asthma and she wasn't going to, you can see Mona's very excited about this. She can't keep it in. But what we want to do now, I think we want to just jump into a simulation. A lot of what we're actually, I think, going to learn from is the after the simulation. So don't worry about coming up here and feeling goofy and awkward. And this is the weirdest type of environment to pretend we're in a NICU that I can imagine. And so you're going to have to do a lot of that, what we call about suspending disbelief and buying into what's going on here. I think we can have about four people who want to be a part of the simulation. And then I want to go the extra mile. We want one of you to be the debriefer. We want one of you to also be one of those that's going to come down here and watch and be the one that sets up to do the debriefing with the other four. So that's 5 total, I can count. And then we will help the other debriefers as well. And we'll I want to get those first 4 volunteers. So who's the 4 that want to be a part of this simulation and help keep this mannequin alive? We can always just point fingers and, all right, yay, we got 1, no.
3.
Okay, that's 2. That's excellent, good start. Yeah, I don't need 2 MDs. One more, and then the special for the debriefer. All right, who is willing to put themselves out there and be the debriefer for the team? Okay, Madhu, come up and be the debriefer. So you get to just sort of hover and look and watch, and you don't have to participate, but you want to get at least a somewhat good view, whether you feel like better about being behind the scenes, seeing what we're putting in the mannequin or not. So again, this is not a NICU. I thought I'd be clear on that. All right, but we are going to have a scenario where we have a baby that's in the NICU. This is the wall of the warmer, the head of the bed, as we say often. So similarly, you would not be able to kind of get back here to do anything to the head, right? So that's why we have him this way, head of the bed, and then you've got kind of your three sides. So that's going to be your baby coming in to see the NICU. Some of your general supplies are here at the bedside. We've got the bag mask, just self-inflating bag. We don't have oxygen here. Can't get you flow inflating or anything like that. You've got a self-inflating bag and work. You've got a stethoscope, Purell. You're going to have to pretend gloves. All right, we didn't bring a bunch of gloves. Airway. So I'm going to put your airway kit stuff over here. Your general airway supplies are right out here, right in front. You don't have to go digging through this tackle box. If you need more advanced than that, then you're going to have to look in here. Okay? Medications, like this is our simulation medications, but they're mostly around intubation medications. So that we all do different, I think, probably on how much we pre-medicate in those things. I'm going to allow you to do a lot of pretending. You can pull out anything and say it's what you think it is, and it goes. Okay? All right? But that is your medication drawer. All right? This one's kind of obvious what this medication is. All right? If you get that far, right, there's epi. You've got a little bit of a suction catheter over here and some tape. And that's where we're going to hopefully have enough of. Anything else, again, because we don't have the perfect environment, you're going to have to just sort of, again, suspend that disbelief, pretend, go with the flow. The other thing I'll say is the mannequin, though, is high fidelity. So while we don't have a high fidelity environment, the mannequin's pretty high fidelity. So I don't want you asking things like, what's the heart rate? You're going to have heart rate monitor. Oh, it went away. It's going to be up there on the big screen. Everybody gets to see heart rate and sats. I don't have respiratory rate, end-tidal CO2s. I don't know what else you might want up there. It's pretty plain. It's actually NRP's program for the vital signs. So it'll be up there, so you can look up there, or you could listen with the stethoscope, just like you would in a real baby. You can put on a stethoscope. You can feel if you're feeling breath sounds, seeing the breath movement, those things. This is the other caveat. You can see he's breathing right now. He needs to stay plugged in, though. So be a little cautious as you're turning, moving things around. That if you lose the plug, you will lose high fidelity. You can keep going, but the mannequin will stop. And we'll try to run over here and plug him back in. So just be a little cautious of the plug. That's all I'll say about that. All right? So that's the start.
Yeah, you probably.
You want that one? You have to turn it on.
So you will be operating like basically in your own rule. So if you're a nurse, you probably want to be the bedside nurse, a doctor, you're the doctor. Can we go? Yeah, so let's introduce yourselves. So we have 3 nurses and 1 doctor. Okay, so that's the scenario. We have a bedside nurse and you have your team outside. Okay? But again, we'll expect that we will hear like the rule exactly all out loud. Okay.
Here's my little one-liner.
So we have baby Tori. He's 4 months old, chronic lung disease baby, 25 weeker, and he's chronically intubated, full feeds, no IV, no access, and was doing fine. The bedside nurse was just doing her routine care at the beginning of her shift. Okay? She will tell you. So, bedside nurse?
Okay, and did we decide roles like RT, MD, nurse? MD.
I can be an RT.
RT, and then what's our?
So, 1 RT and 2 nurses and 1 doctor. Okay? And the bedside nurse, you're doing your assessment at the beginning of your shift. You have your stethoscope, and then our scenario will start.
Yeah, I'm calling the RT to the bedside. We'll turn baby. Okay, our sats are low. So let's go ahead and check the ventilator and see if there's anything wrong with our equipment. We'll say, I'm not sure, so I'm gonna bag. And we'll turn up our oxygen. Can we get a CO2 detector? Maybe, that would be good. See if our tube is in. Check tube placement. We're
No color change.
Okay, so we'll go ahead and take the tube out and bag.
Can we get the doctor over
Okay,
here?
okay, thank you. Okay. 3, 2, 3.
Let me put glass.
3,
Heart rate's 100.
3, 2.
Are we going to?
3,
We're not having any chest rise.
Yeah,
Okay,
there's
can
no
we
chest,
get
there's no
can we
chest.
can we get all the intubation supplies to reintubate? Do you want me to take over the vacuum? It's not.
3, 2, 3. There's a little bit. 3.
Hmm?
You see it?
No, I don't see any chest rise.
No, there's
Just increase the pressure a little bit.
kind of hard with this bag. Go
How
ahead
much
and-
pressure are you doing?
Baby's breathing a little bit.
Do we need any
How much
meds
FiO2
for
you have your?
Any meds?
Huh? Well, I usually don't use meds. I don't have 5-month-olds in my unit.
Baby has some breathing.
So usually it's just an
But I
emergency.
can't give CPAP with this bag, so.
Yeah, no. I mean, he needs to get reintubated. He's a 5-month-old chronically intubated. So, like, let me
Okay.
go ahead and intubate. Oh, these two is like so
Oh, you
like,
probably need to style it.
it's very okay.
It's
Ah,
right there.
Okay, let's see.
Okay, do we have that CO2 detector again? Here.
To start bagging.
Oopsie. Okay. 3, 2, 3, 3, 2, 3.
Yeah, their chest rise.
And the baby's kind of breathing on his own a little bit.
Tube is in.
Oh, good.
Okay, so
We're
like
gonna tape it
tape.
secure. Baby is 4
Tape.
kilos.
4 kilos.
We can put some 10 at the lip.
Yes. How far? I'm at, I can't see without my glasses.
That looks
sorry.
like 10. I see 11.
Okay.
Okay, we're pretending we're gonna put this.
Oh, yeah, newborn.
Secured
I'm
again.
using newborn. Okay. So I can take my, okay. Let's listen to the, we have bilateral, let's get an x-ray.
Scenario's over.
Okay.
Thank God. Good job, good job. Good job, team.
A really good job. And also, thanks for bearing with us. Just obviously, we're kind of working with the conference room technology, which is not our usual sim center. But with that, here, we'll go to our debriefer.
Okay, so let's have our participants stay seated down here. And we can get a chair also for all of us, for all of them. All right, all our participants are down here. And what people in the audience, I really want you to focus on the debriefing itself. And I'm going to participate with Madhu. I'm going to be your co-debriefer, okay? And we're going to debrief together. And then what I want the audience to watch is what we're doing, right? Not so much the scenario of them now. Now what I want you to focus on is how the debriefing's going. And then we're going to want your input into what we could do better, okay? All right, we're finally getting chairs. Okay. Got it? Look at that. All right. Madhu's a go-getter. All right. So, you have a microphone? Okay, we got a microphone, good. It's on.
Okay, let's introduce ourselves so that we can start the debriefing.
I'm Dr. Torres. I'm one of the neonatologists.
I'm Renee, one of the nurses.
I'm Brenna, one of the nurses.
And I'm Stacy. I'm the RT.
Do you want to be our, yeah, we got.
Before we start the debriefing, I just want to assure you that debriefing is just a learning experience for all of us. We want to assure that whatever we discuss during the debriefing, it's just so that we can improve the outcome for the babies in the real scenario. And we'll start the debriefing with that. So, how do you all feel about the scenario? Do you think you were all aware about what was going on in the scenario?
I think so. We knew the baby was extubated, right? We knew the tube had come out or something was going on with the airway, so.
Can you start with, like, what do you think went well in the scenario?
I think there was good teamwork. Assessment was good.
How about you? Do you have anything else to add?
I think we did good with the teamwork, like she said, and recognizing that the baby was in distress and just coming to help fast. So.
Agreed. Teamwork, and then we all had identified roles, so we just kind of stuck with our roles.
Yeah, I think the same. Like everybody knew who was around the baby and which help you had and the resources that you had, and so that makes it easier to achieve the task.
I agree with that. It was a great teamwork, and you all had already decided what roles you were going to have before the scenario. I'm sure that helped with you with that. What else do you have to add?
Well, I would love to hear from the participants. You said you knew what the scenario was. Why don't we just summarize it for us? What was going on here?
So it looks like what was happening was like they could hear the baby cry, and the baby was like supposedly intubated, so or like having like an air leak, or so they thought like probably the tube was not in the right place or was displaced or something like that, and that associated with the low sats of the baby, they assumed that the tube was not in the right place, so they took out the tube and started giving some PPV to the baby that for X reason wasn't like achieving any like good chest rise and an improvement of the SAT. So we decided to reintubate the baby and give like positive PPV through a new ET tube.
Yeah, I think the goals of the scenario, this is a common unplanned extubations. Simply, we didn't mean to, of course. We found the baby extubated for whatever reason, and now the question for the team is really what to do about it. First, to figure it out, and I think you've all said you felt like that went really well, figuring out the scenario. What went well about the actual procedure, maybe, that you would want to talk about?
I mean, I think it's nice when you have resources of like what you need to do as like the next step. So, the RT was actively involved in trying to like PPV the baby while all the other things were getting done. Sometimes you don't have so many people around a baby when some bad things happen. So it was nice that that person could focus on trying to see if they could get any chest rise on the baby, while another person was going and getting all the intubation supplies to be able to intubate the baby. For my part, I think that was the intubation process per se went smooth. I don't know. I know that we can talk about we didn't pre-medicate the baby, but that I assume is part of where you are working, so I only intubate in the ORs, so I haven't intubated chronic baby in a long time, so it's not part of what I do every day, but so that's something that we can discuss, and then the intubation the baby got intubated at the end.
Do you think there was anything during the actual procedure of intubation that could have gone better or you would plan better for next time?
No, I mean, like if I go like, thinking that this is a real case, like the tube was like very flexible, so it was hard to pass it through the cord. So, but I did have the stylet there.
And
I know in
that
TCH
you
we don't use
brought it up
stylet.
that if you want stylet.
We do it in the community.
Yeah. I noticed that when you were doing the actual procedure, it was just you doing everything. You had the tube in your hand and the laryngoscope.
That's what we do every day.
Like, even though you had people around you that
Yeah.
you could have asked for support from.
Yeah, absolutely. Yeah.
Maybe I should not have asked a direct question pointing out, but that's what I noticed, so I brought it up.
How about others around the table? So we were talking about things we could do better with the procedure. I think Dr. Torres mentioned pre-medication. She brought it up. What's your thought about whether this was a baby we should have pre-medicated or not?
Yeah, I think like maybe doing not a full timeout, but like, okay, does everybody agree? Let's intubate, making sure everybody was on page, and then getting the meds and talking about that more before intubation. Yeah, I think so.
I don't know how fast, like in real life, I don't know how fast you get all the meds to pre-medicate or how much time it takes you to pre-medicate. He was clinically unstable. I wouldn't, but I don't have the information about it. How much time it gets you to get all those meds, fill it up, push it in the baby, be effective for the baby to really say, I will do it because it will be in a better outcome for the baby. Like that's the information that I don't have.
Yeah, I was just gonna say, if the baby had responded to the bagging and was stable for a few minutes, like we probably would have had time to pull it up. But because we couldn't get chest rise and we were doing Mr. Sopa and but nothing was happening, so I think that was a good decision to go ahead and intubate.
Okay, I just want to add this, like we're not like trying to find out what actually went bad and what went well in this scenario more than like as we're discussing, we could say like just verbalizing things out loud, just saying, okay, this baby is not stable in my opinion, the baby is desatting, heart rate is not coming up. I think this is an emergency intubation. I will hold off on pre-medication for intubation. So that's the only thing that's probably would have gotten all the team in line and would have taken this confusion out. Okay. At the same time, also, if vice versa is if the baby is stable, then we can say, yeah. And just for you to know, it takes like 10-15 minutes actually to pre-medicate.
And I think the team did really well in like when they were just trying to figure out that baby had actually extubating. I mean, it was like very quick. The bedside nurse noticed that the baby was like making some sound, so probably some air leak. She called the RT assessed, and they realized that it was like really quick that baby's extubated, and they noticed the saturations were low, and they were quick to remove the tube.
Yeah, and this is the scenario we use in our institution actually to improve unplanned extubations, and we have an algorithm developed for when a baby who's intubated is desatting, before people just rush and pull the tube out when it's probably, like sometimes it's in correct place, but it's plugged or something. So we also teach this algorithm to check the ET tube before they pull it out. It's called the PACE. We can go over. But
So
for
in the interest of
time's sake,
time,
yeah.
we wanted to make sure that we also discussed with the whole group the debriefing. So especially because it's being recorded, if anyone has any questions,
you're on the spot. You and me are on the spot, right? So now what we want to hear is from the audience. We didn't explore a lot, but what could Dr. Kulkarni and I have done better about bringing things up? So did we set the stage well? How about we start there? What you thought went well about sort of setting the starting of the debrief?
Or would you have just done it differently, and how?
Yeah.
So just to set the stage for this discussion, actually. To set the stage for this discussion and get the audience more involved, what are the important elements of a good debriefing? So it's
People feel I think that's one of the most important. Like, we're not gonna talk about mistakes, or like we are here to like improve whatever we did, how we can do it, make the people feel comfortable, safe place, like, and get the people engaged. And,
But there are certain phases for going through the debriefing. So introduction, and we can discuss if like how did it go, and the reaction phase, where you give your participants, whether in real life or simulation, time for them to calm down their emotional stress. Like it's stressful even in like knowing this is a mannequin, but still can like get your adrenaline up. So you want to give your participants time for them like basically heart rate to come down. By just asking, how did that scenario make you feel? If it's real life, how did this event make you feel? And for the sake of time, we usually say, in 1 to 2 words, tell us how this scenario made you feel. And then you go to the analysis phase, where you basically just summarize in one-liner what happened. Yeah, so everyone is on board and on the same page. And then you start analyzing the event. Management-wise, like clinical management or medical management, and crisis resource management. Did we have miscommunication? Was there any missing equipment? Could we have done better, like notifying the blood bank for like early, or like things like that? And then at the end, we should summarize the event and discuss the take-home messages. So I think this is just for you to maybe go through all these phases and tell us your opinion.
Does anyone have any thoughts or anything they want to share? Yes.
I think the team did a really good job, the debriefing team, since we're focusing on the debriefing, that they had to get the team really engaged in the communication about what happened. A lot of times people are stunned after an event, and when you start asking a bunch of questions, sometimes it freezes the group. So you came in with the comfort of, like you said, well, what did we do well, or how did you feel that went, and kind of got everybody to start talking about their roles, and then figuring out what they felt went well, and then deeper diving into what things they thought could have been better. Maybe something they identified, I went to go get the tube, but I didn't have X, or I felt like we took too much time with this or that. I think that then people can kind of slow their minds to start thinking about what it was that they identified. Sometimes what I noticed being on this side observing was having that closed loop communication, people talking it out and saying it out loud, so we knew, even though we weren't close up on the field, we could tell what was going on because they were able to communicate back and forth, and the communication needs to keep going even in the middle of the code. And I think that they did a really good job communicating, and that came out in the debriefing, as well as when you asked the questions about, well, what was your role and how did you feel you did in your role, and was there any opportunities? And then at the end, where the doctor talked about summarizing, then going back and say, well, what could we have done to make the outcome better? What could we have identified? I think the summary was really good because they did summarize that they recognized really quick that the baby was having some difficulty. They got the necessary people at the bedside, so that went fairly quickly. And then maybe some, tweaking of some of the, how we did it and what order, because at the end, like you said in the debriefing, it wasn't so much about trying to fix or trying to say we did anything wrong. It was more or less trying to define what we did that we could have done better. And I think that all starts with the communication piece as well. And I think that the communication was very well done. The only suggestion from the outside that I would have made is that more closed-loop communication of talking out, I'm going to intubate, I'm intubating, we have good chest rise, so that everybody in the team knew where we were and what we were doing, so that if somebody could have identified an opportunity, they would have heard something that they might have been able to reach out and.
So if I'm hearing right, you would have focused on some of the communication aspects, like the debriefing, the closed loop communication in the debriefing that we didn't really talk about very much. Well, yeah. Yeah, good. No, I like it. What else?
That's what I put.
Does anyone else have any Thoughts? I agree, and thank you for your comments. I think that the job of the team leader, and traditionally it's not like there's a separate debriefer at the code, it's the job of the team lead, which is usually the MD, but a coach should be led by whoever's most comfortable leading the code. So you could have the CEO of the hospital who's got a bunch of letters after their name, but if they haven't been in code in 15 years, then it should be the RN who just did one last night. And so the job of the team lead doesn't end once the baby is stabilized. It's to also then you're still steering the ship for the emotional support of the team, for the learning experience to be able to do right by that baby and the next baby. And I think that point is well taken. And it's very hard because right after a code, everyone just got derailed and there's a million things to do. And oh God, I was in the middle of a feed over here and this blanket and there's a formula all over the place and this other kid. And, and so I like to try to give everyone like 10 or 15 minutes, if you think you're going to get them back to get sorted. Sometimes that's not going to happen because you had people show up from weird places and you're never going to see them again, but they were integral for that moment and deserve to be part of the debrief. So the second you have the kids stabilized, the team leader should say, okay, let's debrief. And there's no right style. I think that's what we're kind of discussing, but if you can try to stay organized where you thank everyone for their service and you make everyone feel safe, and regardless of what the outcome for that baby is, that everyone there was trying to help. And so you make them feel safe and you appreciate their time and their effort, and then say, thank you, everyone. All right, good job. What did we do well? What can we do better? And then move on in your list, and you'll hit those points. In the interest of time, should we do the second scenario? Or should we just go right to, what do y'all think?
I think we have time for the second scenario, but I wanted to ask a few other things.
Just real quick, and I'm learning as well. How do you determine, when do you, in the debriefing process, talk about why the baby got extubated in the first place? So does that even come up? Because you didn't really mention that part, but it is an important part.
Is a challenge. Some of it is you have set goals ahead of time. You have set goals that this one, we have some set goals in our institution, right? It would be different for this. Some of our goals in our institution is to have a very stable baby and say, let's remind you that pre-medication is an option and we have it available and it is something we do. So that's a goal of our scenario. So we're going to clearly want to talk about that goal if we can get to it. But what simulation is it throws curveballs at you all the time where they do something you weren't expecting. It wasn't part of your plan to maybe talk about. And somebody brings it up in the debrief, and now what are you going to do about it? Or it's something that was off of what should have clinically been done, and you have to address it. You have to be able to say, it wasn't a goal, but we're going to start there maybe even. We're going to talk about that. We could get to, if it came up as a question, hey, I want to know why this happened. My answer would probably be something along the lines of, I don't know, it happens all the time, doesn't it?
I wouldn't want it to be punitive, so I don't know if that would be that kind of question.
No, the questions are, it's why you start with what are you thinking, what are you thinking, what do you think's plus and minus is sort of the idea, is so that we engage them to then be telling us where to go. So there was a moment where Dr. Torres talked about, I know I could have pre-medicated, and she told us I didn't do it, and I thought about it, but I didn't say it. For me, that's a moment, even if I in my mind as a debriefer had, well, I was going to talk about this next, I want to roll with where she went with, right? Now I'm going to say, okay, well, you brought it up. Let's talk about that. Let's talk about it. It happens to be one of my learning objectives. What luck. She brought it up, and now I can talk about that. And often that's what actually happens in the debrief. They end up bringing up what you were already going to make sure kind of came up. The other thing I would say is about debriefing is it's a challenge because it does depend a bit on your goals. It depends on the environment. If I understand right, the obstetric team right now is doing some rapid cycle debriefing, deliberate practice model of debriefing. Now, that's a very different type, and it has, to me, very different goals. If you were trying to get an expert team to do the same technical skills over and over again the exact same way, it can be a really fantastic one. And there, maybe the role for how did you feel about that doesn't have quite the same. I think the outline that Mona told you is a classic one we use all the time. We like it. We like that chance to let the people, but we're often also bringing in even though they're in the same NICU, they're dispersed, they don't work together in the same way, they're not necessarily pod mates. It's the resident that just came on last week. And so there's an environment where if you just throw them and then they start talking, you could get a lot of psychological safety. If you saw in the Apollo 13 movie scene, did I get the number right, 13? Phew. You saw on that, when they debriefed, it was, boy, that was a load of, they just started cussing each other and saying, and you screwed up and we died and yeah, let's run again. They were a team that could handle that with each other, right? They live with each other every day. They've gone through this a lot of times. They had the safety already built in to just be flat out honest with each other and just say it. Most of our teams we pull together don't have that. When I'm teaching people in NRP, they don't even know the other 5 people they're working with. They met them 2 hours ago, and now they're throwing in a high-stakes simulation. And if I go in there and just be like, boy, you guys screwed that up, that is not going to go well, right? So I think this outline works well, especially in these sort of groups we're throwing together that maybe you happen to meet in the conference this time, maybe you didn't. And now you're being asked to kind of do something in an awkward environment and all these things. So,
And I just want to share anecdotally. I was just in you showed up to it. We had an unplanned expedition code that I was leading, and when we got to the grandparents had been at the bedside, and they stayed at the bedside for the code. And not that changes my behavior, but I was super aware of the fact that they were there, and so I remained very stoic throughout the process, and I think I was more conscious of that because of the fact that they were there. And then I led the debrief in front of them, which I had never led a debrief in front of family members because that just hadn't happened to me yet. And I even had the thought, do I lead this debrief in front of them? And I thought, well, yeah, I don't have a choice. Like, I have to do the debrief now, and I shouldn't act differently just because the grandparents are here. And so I led the debrief, and in the part, at some point, I asked, and it was an unplanned expedition, I asked, so what was happening when the tube came out? And I asked in a very just calm way, I said, all right, so I just want to, learn from the situation, what was happening when the tube came out? And the answer was the grandfather was holding the baby. And they were in tears, like they felt so guilty, blah, blah, blah. And so and then I said, okay, I understand. Okay, that makes sense. I'm glad we understand how that happened. That can happen. And I said, I'm so happy it's not something else. Because to me, that was a very easy explanation and like kind of an easy fix. And just being non-punitive and just saying like, okay, I understand. Because I really did just want to understand. Like, that's not the place for quality improvement. That's not the place for your safety scoops. That's not the place for your whatever. You just need to understand. I just needed to understand, was this patient having a departure from baseline somehow? Did that patient need more care in that moment? And the fact that I remained like, so what was happening when it started? Oh, okay, that makes sense. That's all right. I'm glad we understand that. And so the grandparents felt tremendous relief because I think they almost thought like, yeah, what's going to happen? So I just think in terms of the culture of the debrief and what your objectives are, your objective is just to find out what happened and does that patient need more? And if there's safety stuff, blame stuff, like icky kind of, you really do have to address a more serious safety skill that's outside of the scope of like emergencies that happen in the NICU. It's for another place. You know what I mean?
I have a question. So
yes.
my question is for you. So while we were debriefing, you asked for what are the opportunities of improvement if you noticed any during the code or simulation, and then you know that there was something that could be improved for next time, but all the participants, they had not brought that up. So is it reasonable to point that out in a respectable way that I noticed that this happened? Do you think that could have been better next time? Or is it more like finger pointing or blaming that person that why did you do it this way?
So the general method we're using is this plus delta. We're saying what went well plus delta, what can change? What can we do better? What can we improve? If you have somebody that's not bringing up the thing that you think is important to bring up, either it's just not recognized or for whatever reason it's not being said, I think advocacy inquiry is a different type of debriefing tool. And so there's all these tools. I think about, Dr. Grant's talked about it, like a tool belt. You've got all these different choices of ways to help these simulation people. Maybe in this case it's RCDP, maybe in this case. Advocacy inquiry is a way where you ask a question, essentially you point out the problem. I noticed that you were intubating with your right hand. You were holding the blade with your right hand. So I just flat out tell you what happened. This didn't really happen. Okay, so I flat out say, no. I flat out say, I point out the problem. You were trying to hold the laryngoscope blade with your right hand, right? So then I don't like you squirm around thinking why I think that's a problem. I think that's a problem because the standard learning scope is meant to be held by the left hand, and it would block your view if you were holding by the right hand. Then you get them the opportunity to explain their frame. How did you see it? What was going on in your mind? That's an advocacy and inquiry question. So I'm not fishing around for something. So, what hand do we hold the blade with? Right? Like maybe they just don't know, right? You ask all sorts of questions like this, and people are like, what's he trying to get at? I flat out just say it. You were holding the learning scope with your right hand. NRP, everybody that teaches intubation says hold it with your left hand. So now I point out why I think it's a problem. That could obstruct your view. How did you see it? And you've been amazed by the answers you get. Sometimes the response is I've never intubated in my life. I don't know why I'm up here handling this plate. Oh my God, how did we get you this far in the class without you knowing that, right? Or you find, gosh, I actually was just in a class like week, and this is exactly how they taught me to do it. Wow, right? Like you don't really know why they did what they did. You can only, we talk about a lot, I heard once that we judge ourselves by our motives. We judge other people by their actions. And this always plays out for me in traffic on the road, right? Like I always know why I accidentally cut somebody off. I have all these great reasons. They should forgive me. I don't know why they're blaring their horn. But when that guy cuts me off, it's clearly because he's a jerk and he's an evil human being and he deserves to be run over, right? But we don't know what's going on in people's lives. And so it's similar in simulation. We don't know where they got to the point where they made that mistake. Sometimes it's as simple as, oh my gosh, I know that. I'm just severely right-handed. I just couldn't even, whatever, right? So when I get a person who didn't bring it up, that's the time I put it in an advocacy inquiry. I'm going to specifically point it out, tell why I think it's a problem, and then ask them to explain their viewpoint for me to really understand what the problem is. Because if they tell me, this is how I learned it, then I can correct that problem. But if that's what I assume is a problem, and that's what I try to correct, and I find out later, I have a contracture of my left hand. I can't even use my left hand. I have to use my right hand. Well, I wasted a lot of time yelling at them to use their left hand when they can't, right? I'm just making this up on the fly. But this is the ideas, right? That once you get to their frame, now you know what to actually correct, right? If you don't get to that, they're just going to keep, you can tell them all you want, but I can't use my left hand, sorry.
So Madhu, I will say that actually you did also a good job by establishing safe environment. Just sitting, having your eye level at the same level of the participants, and also acknowledging all the participants and allowing them to all share their thoughts is really very important in any debriefing. And also building on what they say. Sometimes people are different, so some might want to talk, some might not, but the ones who internalize, they want the invitation and feel safe. So you did a good job with that. The most important thing also to remember that a debriefer is not a teacher. As a team leader, I might not know everything, and a debriefer as well. I'm a facilitator. So that's the difference between a good debriefer and a debriefer who basically dominates and not allow people to vent and get the purpose out of the debriefing. For what Anne was saying, you could decide on the objectives of your debriefing if it's a simulation, but if it's a clinical environment event, then you probably also want to get talk about things that you should not be repeating with the next baby. So you don't want to be doing the same mistake or having equipment deficiency with the next baby in the next 10 minutes. So that's one of the things that come out of the clinical debriefing. When you get to the habit of debriefing all clinical events, it becomes safe for people. So I know I'm being called to this debriefing, not because I did a mistake or I screwed up or the baby died. It's because that's the best practice.
And so I think with that, if we want to do the second clinical scenario, we'll move into that, and we will make sure there's time right after to make sure that you can just practice and intubate. And are you all headed out? Did you want to do any skills practice before you leave? We can. Okay. All right. Well, thank you for your time. I hope it was fruitful. For those of you remaining, no, okay, you're welcome to try any of this. Okay. Of the people remaining, Of the people remaining, would you like to participate in the sim? Yeah, okay. So like another 4 people, would you be interested in doing that? No, there aren't 4 takers. We have 1. It can be the same people if there's a paucity of volunteers.
I just have a question.
Yeah, absolutely.
So, a lot of the talks have been on quality initiatives and quality improvement. How does your program incorporate simulation into your quality improvement? Do you start with, there's a project that you think will benefit from simulation to help roll out, or?
So we actually use a lot of simulation. What's that? Oh, repeat the question. How do you use simulation in QI work? I really simplified it down, right? But is that I'm gathering the question correctly, correct? Okay, so yeah, we do. It's probably so much that I'm gonna have even a hard time kind of giving you a specific example. But for instance, one of our RT educators, Suzanne, is brilliant about going around and making up little games and things, and where it just goes around in the clinical, and you go bedside to bedside with your mannequin, and you just make them pick out the right equipment, right? If you're having a CPAP bundle, just have them put the bundle together on the baby correctly. Go over it again. Do those sort of things, so that would be a way to incorporate that into as you're working on a CPAP bundle as part of your education. We usually use it in the education and kind of the rollout, right? So I'm trying to think of a way we can use simulation as part of ongoing QI work as it's already been rolled out. I think one of the things that we've tried to do now, we have in our system where we track and log all of our simulations we do. Sometimes what we know happens is something gets actually identified in that scenario. Again, it wasn't part of the planned objectives. Nobody set this up, but something happens. And you hear about, hey, in the real clinical environment, this is actually happening. This is a problem. This is going wrong, and we need to get this fixed. We actually now have a way to log that more correctly and database store that so that we can, now, the next step would obviously be really great is to actually get that to the right person. But we're actually starting to at least log that now, where we're logging what concerns came up as part of that, so that we then can take that to that and say, hey, look, in the last month over in Site 2 Sims, these are the 5 things that came up as potential problems that our medical providers are finding in the unit. And so that's one way to use it as a way to identify quality issues. I don't know that that's exactly a quality improvement in the same way as having a nice run chart and going on where things go. What other ways any other thoughts on QI work with the?
Like on potential projects or on things we've done?
Which one?
I would say that I think when it comes to sim and resuscitation, there's a lot of just-in-time training that I think is underrated. I think when you see the potential need in the unit, as Nathan said, we often have a lot of, if not learners, you have people floating, or you just don't know who you have in a unit at any given time sometimes. And so periodically realizing, oh, this might come up with this baby tonight, and doing just-in-time training, if it's for SVT, and a kid in high risk for doing that is a big deal. And I know that there have been initiatives about sort of, especially in the PICU, about talking about just-in-time training. I would say that I also then have my own things that I just do periodically with residents all the time about the difference between a self-inflating bag, a flow-inflating bag, and a neopuff. But that's not in a formal capacity, but certainly an idea to just be constantly doing little things in the unit that I do think make a difference, just because I know that's not what you're supposed to say as an evidence-based person, but I do see the result, a week or two later when someone demonstrates knowledge. So I think as a teacher, for sure, and that those things have opportunities for proper QI projects if one had the initiative to do it.
So we actually use our Insight Sim for our QI as well. What I was talking about for the previous scenario, unplanned extubation, is training people on the pace. So basically, when a baby is deciding, is intubated, P for pressure, A, auscultate, because we had people just pull the tube without even listening. C is the chest rise, and E,
End-tidal
tube,
CO2.
end-tidal CO2. We're adding to it also S to make it space, so it's suction as well. Sometimes it's a plug in the tube is in. So that's one of the projects. We also had like basically hand hygiene concerns. So we built it into our Inside Sim that because we want people to participate in different scenarios, but not walk out of the Inside Sim thinking it's okay to touch the baby without hand hygiene, without the gloves. So we like you can always incorporate quality improvement initiatives in your Inside Sim. And you could see the change, like, or the improvement when you get the participants to participate again. These little things you talk about, they will always remember it.
Yes, I just had a question on whenever you're incorporating quality improvement with your simulations and you identify need like the unplanned extubation or setting up a cooling blanket or something like that. Do you do just mock simulations and just catch who you can catch? Do y'all have a requirement of this is a need, you have to have this simulation? I mean, I feel like there's so many needs at so many different times. How do you catch all this
That's where the
stuff?
buy-in comes in. So
Yeah.
actually, this past year, we got our leadership to make it mandatory. All attendings, all physicians are mandated to attend 2 Inside Sims a year. All our nurses are mandated to complete online course and participate in Inside Sim at least once every 6 months. So it also takes close work and communication with leadership. So the NNP leadership, the nursing leadership, physician leadership. And once basically you get the organizational buy-in, like it becomes part of their routine. So we have our Inside Sim twice a week, and people know this time to that time, like it's 45 minutes only. You're gonna be called for Inside Sim, and you need to participate.
I think for your question, it depends on your quality improvement about what you're doing. So what you're saying, I think what I heard the question was is sort of what ways can you do it? How can you incorporate? Can you really get all of that out of this? So a lot of what we're describing, because we're both directors of the Insight Sim program, is this full scenario, kind of like what you saw here coming in. And we can incorporate some things in there, like the hand hygiene, but some things you're just going to have as part of QI. It's totally separate and done. And that's what I was talking about with our RT going around and just having a mannequin, usually low fidelity, just going around bed space to bed space, just doing that as part of education and reminding of the bundle or whatever it might be. So you can incorporate it that way. It doesn't have to be the full-on scenario-based sims. You can do very directed. I'll give you a free one. I thought of this. I really want to be able to do this one day. All right? So how many use flow inflating bags in the NICU? I'm assuming we're all sort of neonatal-ish. Is that a fair assessment? Flow inflating bags in the unit? Hands up. Flow inflating bags? Self-inflating bags? T-pieces with each bedside? Really? You guys are my heroes. All right, for the flow inflating bags, here's what you need to do. You need to design a QI project where before anybody can come on a shift, they have to bag a mannequin for 2 minutes straight with a flow inflating bag that gets effective chest rise. And if not, they can't clock in. Wouldn't that be amazing, right? If every day you showed up, you had to work, you had to actually handbag. Now, and what if you could do it for the teepees? You could do it for anything, right? That would be like just a daily reminder that, okay, this is like one of the most important things we do. And I will say for the flow inflating bags, it's one of the worst things we're at doing. But just to remind them how to get a good mask seal, how to do those things. If you just had to come in every day and bag a mannequin for 2 minutes before you could start your shift, I bet we'd get a heck of a lot better, right, at things, no matter what your equipment is. So some things like that is a way to incorporate it, not that hostile where you can't clock into it, but again, if roving sort of sims, hey, thank God you haven't had to handbag your baby today. I've got a mannequin here. I'd like you to just practice for a minute. Just keep your skills up, right? Those are ways you could put that in. You did that for a couple months, looking at find the right output for your QI project, find the right thing to track. You might find that you have fewer bradycardic episodes with unplanned extubations or whatever it is you wanted to look at. So those are ways I think about how you can incorporate into QI.
We
do, it didn't occur to me, but we do, so as fellows, we go between our really big, fancy Texas Children's, Ivory Tower Tertiary Center, and then we also do a community hospital, Bentov General Hospital. And at Bentov, which is a much smaller unit, at the top of every shift, so every 12 hours, we go through what we call a mega code, where we talk through, in the event of anything on that shift, what is everyone's roles, who knows what to do, how to call people, what does Mr. SOPA stand for, and we do that at the top of every shift. And it's just, we talk through the algorithm. It makes clear also for that shift who's who. So people may, I may be covering a call for someone and no one's ever seen me before, that happens to be working, and they're like, oh, okay, that's the team lead, cool. We wear badges. My badge says team lead, like just a little, like in addition to my, credentials, it just says team lead. MD2 will be the resident, MD3 is the intern. RT, even though we have more than one RT, that person is going to be the one that in the event of a code is your bedside RT for crowd control. And meds and recorder are our badges. So we do that at the top of every shift. It's much easier to do in a smaller unit, and might be a process that is. And so what we do is the pager goes off like 9 p.m., and that calls everyone to the unit to talk through the code. And we do that every time. So everyone's at least clear on their roles. You don't practice skills at that time, but we talk through who would be doing what. And then if questions arise and there's time, I can always take, I can take someone aside after for simulation stuff with what we've got going on. So I hope that's helpful. And then in answer to the checkoff stuff, at TCH, we have things that periodically rise. So one of them is the FIDO trial, if you wanted to talk about that. But we have things where we do kind of have things that come through the unit where it's like everyone needs to get checked off on these skills. Like you need to be checked off on this, within the next 3 months. And yeah.
I think I was going to just say, so again, debriefing for a technical skill is a very different type of debriefing than if it is for a teamwork-based sort of scenario. So there again, I don't really particularly not concerned if you're happy about the fact that you got the intubation right or not. I'm happy for you that you got it, but what I really need to know is can you hold it in the right hand, pull the skill, lift up the blade, hold the tube in the right hand, put it in the get it in the trachea instead of the esophagus, things like that. So that has a bit of a different, more what we've kind of gone to in our NRP program, calling ourselves coaches. So we're there to coach you through this and get you better, assuming that you've already came with some basic knowledge. Very few people have got your unit and never learned that skill ever, right? But occasionally you are going to be rolling out a new skill. The one Ann was referring to is that we do a lot of crazy things at Texas Children's. And one of those crazy things we do that's probably being helpful is take severe CDH babies, and while they're still fetally inside the mom, we put balloons in their trachea and fill up the balloons with fluid, and that helps their lung grow so they have a better chance of doing it. But the major problem with putting a balloon in the trachea is you got to take a balloon out of the trachea before they're born, otherwise you're going to have no way to ventilate that baby. Now, that's all well, nice and good and planned, but what if a baby was born with the balloon and still in place, and you would be unable to bag mass ventilate that baby, or endotracheal intubate and ventilate that baby? And so we actually had to come up with a set of scenarios for our neos. We were sort of the last line, the ones always in-house. The ENT guys could be coming from home, the surgeon from who knows where, but the neos are going to be there. We have to find a way for them to be able to do this. If you're ever in the very unlucky circumstance where one of these babies is born with a balloon still in place. So we came up with a simulation to train our neonatologist on how to do it fetoscopic, not fetoscopic anymore, neoscopic, I don't know, whatever. You take a scope, go down, pop the balloon before you would then be able to put the ET tube in. So that's ones that we came up with several months ago that I'm training all our neos on. Now that's me demonstrating it, watching them, coaching them, telling them, giving them all the tips I know, showing them where to place their hand, push this here, look there. Now do it again. Do it again. I'm not going to say as much this time, okay? Just walk. Yeah, you've got it down, And knowing that one time's not enough, right? Then that's where I'm going to want to have sort of an ongoing basis where I'm touching base again. Hey, I know I took you through this before. Let's go back down to the sim lab and let's go try that again, right? So I think how you debrief, what your program, what your QI projects could potentially be, those will drive what you can do with the simulation, more so than I have this great simulation. How can I push it to make it do everything else? right? Maybe that's the way to think of that.
And it's
Feto example is needs arise, so that's something that we all had to get checked off in, and I imagine we'll periodically repeat. So with specific things, you know, you have the overarching things of things that every NEO should know, every Morgan and NICU should know, but then there are technical skills that usually those questions arise out of some catastrophic event. So it happened because it is a separate hospital in a totally different region. There was a catastrophic event. So we then respond to that by inserting very specific simulations that everyone has to do, you know, on the fly.
And it's not just for new procedures, but also to maintain the skills. So we also have a course, you also participated, new special procedures where all physicians, all NNPs are required to do all the neonatal procedures in SIM every 24 months. But actually, NNPs do it every year. Physicians do it every 24 months, including our community physicians, neonatologists. Okay, so now I think we should move to our scenario.
Well,
No?
I was going to say something different. I was going to say, I feel like we've kind of gone over the time we had planned on for this part of the scenarios, and I do think we've got a smaller group than we were planning on. We had heard big numbers, which is great. But I think this has been great question and answer. Let's continue that a little bit, and then I do think we can then, again, you guys can come up. We wanted to do coordinated chest compressions, ventilations with the mannequins. This one has a very unique output to be able to kind of show some of that, just do some hands-on demonstrations with those things. But yeah.
So our unit still struggles with, after a clinical event has happened, debriefing right then. So have you just always been able to do that, or how did you implement that and make it a priority? Because we've discussed it, everyone agrees that it should happen, but then it just seems like it's so busy and people have other babies to take care of, and you know, the RT goes back to whatever they're doing, and it doesn't happen.
So I'll talk about how we've done it as part of our delivery room team service. So we've in stages have come up with all of this, but starting with was, so there's two types of debriefs, right? In what we're talking about, a clinical debrief, there's a hot debrief and a cold debrief. A hot debrief just simply means it's relatively soon within after it's happened. The advantages of that is people don't forget things, right? They remember because it just happened. It's seared into their brain for at least the next 5 minutes. And so if you can come in right after that scenario and talk about it, the right thing that happened, people are going to be able to remember better what happened. And sometimes getting to the what really happened, what went wrong, is maybe better at that moment, so that you can get the right answers to what actually happened. But obviously the other side of that is that we're busy, we're in the middle of clinical, we've got to get on to the next step, and sometimes the emotions are so fired up that you can't see straight, and debriefing in those environments are hard because feelings are more easily hurt. We're already feeling bad, and then the blame things and the psychological safety all come into it. So there's some advantages, disadvantages. Cold debrief is we just go away. 2 days later, we come back, we sit in a conference room, we try to look through, maybe we have some notes to get some basic understanding of what happened. And that's a bit more of a time, okay, I've had 2 days to sort of reflect on this, think about it. I'm in a better state, I'm not emotional, but here's the questions I have. But so people may not remember, oh, you're saying I did that? I don't remember doing that. And nobody has video, nobody can do that. So some advantages there, some disadvantages there. We do both for the delivery rooms team. What we've asked them is we're very busy, so number one, it'd be silly to ask them to debrief every delivery they go to. They would find me and kill me if I tried to tell them to do that. But what we've said is, okay, let's try to pick the subset where we think something could have happened that we could actually learn from. And it's not every baby, because I think you can learn from every delivery, for instance. You can learn from every time your delivery team goes together. But if in the end the debrief is always, well, the baby came out and he cried and we all knew our roles, you know, it's not very valuable. So we said if it ends up in an admission, we're going to presume that an admission means the baby had something enough that maybe something happened. Doesn't always, right? Sometimes they come out, they're 34 weeks, they just don't make our cutoff, they're on room air, but we're still going to bring them down. So we try to pick a subset where we think, well, that's more likely to happen. So debrief all of those. And the way that it's worked is either sometimes if we don't have a family member with us on the elevator down, we just do it right there in the elevator. Or right after we get to the bed, we're pushing the baby. We have a system, and it depends on your system, but we're handing off to the admission team. We can then just step right outside the door at that moment and say, okay, before everybody starts running off, Let's do it now. And it's been pretty effective. It waxes and wanes. When I check the numbers, we're doing it good some months, and some months we're doing awful at it. And it really does depend on the busyness of it. As for the cold debrief idea, we have a monthly conference that I just started a year or so ago where we sit in a room Tuesday morning. I have a case. I read through it step by step. This is what it says happened. This is what it said happened. This is what it said happened. What's the right thing to do that? Ideally, I want the people who are actually there, but in this case, whether they're there or not, we're still learning about how a case was done. And wow, this doesn't make sense to the NRP algorithm. We would never want to have done this before this. What is it that could have happened that made that happen? What is it? Why would we do that? Or is this a situation where that's totally okay? You know, the NRP algorithm isn't perfect. It doesn't know everything. And so we have a cold debrief sort of scenario. So the reason the Tuesday morning one works, the monthly one, is because I bring donuts. Cold debriefs, food is key. I'm just going to say it. Like, if you really want to get something going, offer them food. And then the hot debrief, we're hoping, again, it's just built in. It's a little more driven by who's there, willing to just speak up. I've never found anybody to be like, no, I don't want to be a part of these. But just the time to do it is the more big factor there.
And I think what helped with the delivery room, actually, the briefing and the delivery sheet or a document, they have 3 questions. Anybody can ask them because the briefing takes training and not everybody is trained. But these 3 questions are the briefing questions that's straightforward. What went well? What could have been done better? Any equipment deficiency? So these are the things that they can quickly fill in or just ask the team and done. The briefing is done. In the actual NICU, the briefing depends on who's on and who's comfortable. So yes, I will say we don't do debriefing for all events that happen in the NICU yet because we don't have enough trained people, and sometimes badly conducted debriefing is worse for the team and for the outcome because if you're not comfortable, you might make people even feel worse or make it all unsafe for their mental health and their performance afterwards. So to start, you need really good trained debriefers who are available 24/7, and we don't have that yet.
Well, now allow people to be hands-on for those of you who are remaining, and we really appreciate that you've hung out till the end. I know we've lost some people along the way, but we did promise you hands-on time. So this baby is this is for coordinating CPR and chest compressions and making sure you can do chest compressions and bag in the right rhythm and do both those effectively. And then on baby toy or high fidelity doll, you can practice intubation, and you can also, if you want, we can manipulate the vitals and you can listen and, we can just kind of talk. So this can be sort of tutoring / airway, and this can be 2 people at a time doing CPR and chest compressions.
This baby we actually used for quality of CPR research. And the good thing is the SimPad actually gives you feedback on time on the chest compressions and the ventilation parameters. So chest compression, it will correct, will tell you, do you need to place your hands a little lower or a little higher, the depth and the rate. And I'm gonna walk you through it. And the same with the BBV, it will guide you if you need to put more volume or less volume to be effective ventilation. So feel free to walk to any of the stations and we'll help you go through it. Yeah, thank you all for your time. Yes. The study finished, but I'm using it for quality. So this baby doesn't do NRP. He does just BLS. Yeah. So are you gonna if you're gonna go? Yeah. So 15 to 2, then 2 rest core. Okay. So chest compression starts first, and you can see if you're not deep enough, you will be not reaching it. Yeah, so this is, no, there's no too deep. Yeah, now, do shallow. And now actually it's correcting you because the rate, because you stopped. Here it's saying go deep. The rate, you want to stay within the green. If you're too fast, it will be red, and if you're too shallow, it will be yellow. Or too slow. So you need 15.
I was like just paying
Only this one.
So you don't do the 1, 2, and 3.
Oh, you want to reset?
Yeah, let's start.
Because we like
Oh,
got
okay.
accounting.
Do you do 1, 2,
And it
3,
will not,
breathe,
it
or-
will not, no, it's 15 to 2. It will not allow you to bag actually until she finishes her 15.
Okay.
Oh, okay.
Go.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15.
Okay. Okay, so you're not, like, it's not detecting it because it's like you need to correct. So here, so this is too much. So you
because
try
of
to
the
be
pressure.
blue in the middle. Yeah, excellent. And now she can.
Oh, it's so, yeah.
So it's a good practice. I have also like I have the rest.
12, 13,
You
14,
want
15.
can increase to 1
Stop, 15.
No, we don't have the NRP ratio. Then you continue the 15, and then at the end, actually, you will get a score. We were using the score for
so
my
hard with this.
research project.
Wait a minute.
Basically, it
What
was
is
more
the-
like
what's-
rewarding for people. Oh,
What is the
I got
routine?
99.
What should
Oh,
you
I
be
got,
doing?
oh,
15 and then bag?
and then two breaths.
We made it like a
Well, they have
15
15
breaths.
too. They don't have 3 in 1.
Pulse algorithm set up in this, not that.
They don't have the
So you
Neo.
can't do the, this is
3
for a
in 1,
bigger,
3
this
in
is for a
1.
bigger
Yeah.
one.
Yeah,
This is for a
they were able to
PIC.
PDs.
Okay, so,
let's do
so
the other way.
so no, do for PD, so it's 15 and 2. 15 to 2 for them.
30%.
Oh,
For
y'all
my
did-
bagging.
Oh. That was sad.
that by itself is what got people to keep practicing.
Yeah, because but you go to
Because they don't want 31%.
you go to 20 and it shows you too high, so be careful.
Okay,
That's what I thought.
sometimes just the delay for
1,
chest
2, and
compressions
3, and 4,
will
and
mess
5,
your score.
6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 1, and
See?
2,
And it's
6,
full
7,
2
8,
minutes.
9, 10, 11, 12, 13, 14, 15.
It's called RQI.
Yay.